will share session objectives. And thank you, Luis. Our session is going to be recorded, and the recording will be available on our YouTube channel for those of you who might not be live here today, but might want to watch the recording later. So the objectives of these sessions are first to give you a very brief introductory overview of the core program and its focus on oral health inequalities. Then to highlight conceptual, theoretical, and methodological approaches in oral health inequalities research. And finally, to discuss the implications of those conceptual and methodological approaches for future research on this area. So first, now let me share some details about the core program. So as you can see here, CORE stands for Community Focused Oral Health Research for Equity. This is a program funded by the National Institute for Health and Care Research, NIHR, in the UK, and it's a collaboration between different institutions across countries, so across Brazil, Colombia, India, Kenya, and the UK. Now, in terms of our values, we think that innovative community-based approaches are needed to challenge the status quo and dominant Western narratives and approaches. We also think that it's essential to ensure that principles of equality, diversity, and inclusion are embedded in all aspects of our program. Similarly, all the program's components are based upon respect, transparency, and build trust between stakeholders, communities, and across all institutions and collaborators. Another value is fairness, so to make this an equitable collaboration. And we also are guided by this idea of learning from each other, from our communities and collaborators, so mutual learning, and finally, capacity building and strengthening. Our program has different work packages. These are the three of them. The first one is on this topic of the webinar today, oral health inequalities. It has different studies within this work package. The second one is focused on commercial determinants on oral health. And the third is on system reform and innovation. So different studies and approaches to guaranteeing equitable access to quality dental care across the different countries with a special focus on vulnerable populations. So even though oral health inequalities is the topic of our first work package, I will say it's also a cross-cutting theme in the sense that all our research, our community engagement and involvement activities, our training and capacity building activities as well, all of them are guided by this principle of equity and social justice in oral health. So our webinar today will be, as I said before, dedicated to this topic. And to start, we have the first talk on called Social Epidemiology and Inequalities Research, Theory Matters. For this talk, we have a very special speaker, Professor Marco Perez. So Marco is a dentist from the University of Sao Paulo in Brazil with a PhD in epidemiology, also from the University of Sao Paulo and University College London. He is a research director and senior principal investigator at the National Dental Research Institute in Singapore and Duke NUS Medical School, Singapore. Marco is a member of the Lancet Commission on Oral Health and is an international collaborator of the CORE program. Of course, Marco is also a dear friend and colleague. Thank you, Marco, for accepting the invitation to speak to us today. Welcome everyone again. I've seen that many people have entered the session in these minutes. So welcome everyone, wherever you are. This is an exciting webinar of our core program. And please, Marco, it's over to you. Thank you for being here. I will stop sharing my screen and lovely to have you in this webinar with us.
Thank you, Carol. Thank you, everybody. Can you see my slides? My slides?
Yes, Marco, we can see them. Just to remind you, you have 15 minutes, and I will let you know when you have 2 minutes left, if that's okay.
Please
Thank you.
don't count the first talk. That my thank you to you and Richard, and thank you very much. Very happy to be here for this kind invitation to present today, the opportunity to share this webinar with my friend Ankur and with Ross as well, and all those people who are attending early morning, afternoon, or maybe like Ankur late night. So actually, my talk today is to discuss some theories. I don't know if you will be interested in, but this is something that affect me recently, has been affecting me recently, and some of my reflections I decide to share with you. So basically, as researchers in this area focus on health inequalities, frequently we face some questions like, what's the most suitable theoretical framework to apply? How do theories align with existing empirical data? Especially since as an epidemiologist, we often analyze data that has already been collected. As a scholar in this field as well, and an enthusiastic reader, I have observed an increased body of work on oral health that examines intersectionality, both theoretically and empirically. So my curiosity was I trying to understand what exactly is intersectionality and what are its origin. And going back in my past, I was curious about the concept of social class as well, and how this concept has been used in health research, and particularly in oral health research. If this concept is more effective, the concept of intersectionality is more effective, social class, in explaining the mechanisms that produce social inequalities in health. So basically, for those people with different backgrounds, I would like to start a very brief presentation, present some basic concepts of social stratification, the usual methods and measurements of socioeconomic position and its limitations, and to introduce the concept of intersectionality and some of these critiques that exist, and to bring back the social class. So I call it social class revisit, and provide some examples in oral health research. That's the journey, very short journey. Please, Carol, let me know when I have just a few minutes. Well, basically, this busy slides just to show you that my discussion primarily focused on describe and explain inequalities in oral health. To do that, it's necessary to understand social stratification as a foundation concept for newcomers to the field of social epidemiology. Well, the term stratification is derived from the word strata, which refers to how different types of rocks are staked to create a rock strata. Social stratification refers to the division of society into a hierarchy of unequal social groups, resulting in distinct strata. These groups interact with one another regarding various advantages and disadvantages, such as income, wealth, occupational status, race, and gender. And depending on the specific stratification system in place, as you can see in the slide, generally those at the top of this hierarchy possesses more power in society compared to those at the bottom. Well, sociologists have identified at least three major types of stratification system. As you can see, the caste system, the feudal system, not going to talk about. I'm going to focus on social class. Basically, the concept used by Karl Marx and Weber. As you can see here, there are at least two well-known concepts. For Marx, social class is defined by the relationship of a group to the means of production, which means the land, factors, and capital used to produce goods and services. He identified in his seminal work two main classes, the bourgeoisie or capitalist class, who own the means of productions, and those who don't want the means of production, or the proletariat, the working class. Marx's concept of exploitation is rooted in conflict between these two fundamental classes. In contrast, Weber defines social class as a group of people who share similar situations, particularly in terms of economic life changes, and he identified different dimensions: economic factors, social prestige, and political affiliations. As you can see here, this is the initial definition of social class by occupation used in the UK, for example. I know that this has been replaced by the standard occupation classification with a kind of variation. But in short, this is the two main adopted social class. So interesting, this slide, a well-known example of this kind of approach of the impact of social class in the percentage of children under the age of 7 who never visit a dentist in the UK. This data came from the Black Report, a very famous report about health inequalities in the UK. As you can see, there are a distinct socioeconomic gradient indicating that children from high social class were more likely to utilize dental service compared to those for lower social class. Well, usually in epidemiology, what are the most used socioeconomic indicators? This book that I presented here, edited by Lisa Berkman and Kawashi, presents a very comprehensive overview of it in one particular chapter, if I remember well, chapter 3, written by John Lynch and George Clapham. So they propose that income and wealth are key indicators of the ability to afford essential goods and services, including food, housing, and healthcare, and they help identify vulnerable groups and track the progress of social and health equity over time. However, income can often be underreported and may fluctuate over time, while wealth data is typically less available than income and educational data in traditional way that we collected data. On the other hand, education is frequently used as a stable indicator of socioeconomic status throughout a person's life. Occupation can indicate social stance and work-related exposures, but this may not be relevant for retired people or unemployed individuals. Also, area-level indicators, and here we have an iconic picture of my hometown, São Paulo, showing the division of two different neighbors, very, very famous photos. Area-level indicators reflect contextual effects and are very relevant in terms of policy, make them useful when individuals' data is unavailable. For those interested in this topic, I recommend also reading Anchor's paper that I display here on income and oral health, a critical review, as well as the research on area-level income and oral health that he adopted in Australia. So, however, the use of only one dimension of socioeconomic indicators, such as income or education, has been criticized. I don't know if you are familiar with this lady, but this is Kimberly Crenshaw, an American civil rights advocate and professor of law at Columbia Law School. She introduced the concept of intersectionality to explain how Black women face overlapping forms of discrimination that are not sufficient addressed by frameworks that focus solely on race or gender. She critiques legal and social systems for overlooking these intersections, which leads to a lack of visibility in policy and protection. So very seminal paper that you can see in this slide. So subsequently, studies progressive used intersectional. So move beyond the single X analysis by employing sophisticated, stratified, and interaction models in epidemiology. These investigations explored how various combinations of identities affect outcomes, considering the roles of racism, colonialism, and capitalism in shaping these identities and their impacts. So I didn't conduct a systematic review, but I did a quick review combining intersectionality and oral health in PubMed, and I found, as you can see, 12 papers, most of them from a group of people based in UK, in Brazil, in Australia. You can see the intersection of socioeconomic position, looking at the gender, ethnicity, nationality. So all of them attempts to move beyond the single axis of socioeconomic inequalities. So despite progress in understanding social dynamics, the concept of intersectionality has been criticized as well. One notable critic is this guy, Eric Olin Wright, an American sociologist and Marxist theorist known for his significant contribution to the study of class inequality and social transformation. He modernized, as you can see in this table, the Marxist class theory to address the complexities of the contemporary capitalist society better. He rejected the traditional binary model that I presented, capitalist versus working class, and proposed a more nuanced theory as illustrated in this slide. While he did not directly critique intersectionality, his ideas have influenced many of its critiques. One of them is this famous scholar called Barbara Foley. Foley acknowledged intersectionality in discussing the overlapping oppressions of racism, sexism, and class. However, she argues that its limit in its analytical capacity. According to her, Kimberly Crenshaw, the person who proposed intersection, her metaphor of the crossroad where race and gender intersect in spatial and two-dimension, failing to consider deeper material structures. Rather than addressing the foundations terrain on which oppression is built, it primarily describes symptoms. Foley contends that an emphasis on identity, such as race and gender, can obscure issues of class exploitation. For Marxists, it's crucial to differentiate economical and structural exploitation and oppression, which is based on cultural identity, intersectionality. In Foley's view, flattens this important distinction. Another community figure in this field is Vicente Navarro, a Spanish-American sociologist, a Spanish who moved to US in the time of the Civil War in Spain, a public health expert known for his strong critiques of the prevailing ideology in public health and policy. By the way, he also critiques the social determinants, the way that you understand. That perhaps deserves some comments after that.
Sorry, Marco, to interrupt. You have 2 minutes left.
Okay, I'm finalized. Navarro's work is significantly influenced by Marxism, and he recognized is recognized as one of the key figures in connecting political economy to health inequalities. He agrees that health inequality are fundamentally political in nature, reflect the power and structure in capitalist society. To finalize, I'm going to show, so another curiosity is to look at the literature in this field using this kind of typology and theory. In this slide, I present concrete examples of how Marxist social class analysis has been applied in epidemiological studies. And I want to highlight the outstanding work done by Brazilian researchers, including my mentor, Cesar Victor. In the 80s, last century, he published a seminal paper that utilized empirical data from the 1982 Pelotas birth cohort study to operationalize the concept of social class within the context of epidemiological research. The question is, are there any examples in oral health research using this kind of approach? So surprisingly, very few. Very few studies have used this concept. Again, I didn't conduct a systematic review, but a quick search on PubMed revealed only 3 related publications. One example, which you can see on the left side of this slide, is my PhD thesis, publishing more than 20 years back in the Brazilian Journal of Epidemiology. I applied the classification proposed by Victor and colleagues that I mentioned in the previous slides to examine the impact of social class on the occurrence of dental caries in childhood. I have an interesting fact to share. When I submitted the second paper of my thesis as a young researcher, I was suggested to change the terminology in CDOE. I did this reluctantly, but as a young researcher, I accepted. I need to confess now. As two other papers I found published by my Korean colleagues, one of them in CDOE as well, and represented the only exceptions that I could identify. So, as not a conclusion, but perhaps an invitation, we should collaborate to address the methodological and theoretical challenge that prevent us from applying more robust approach to understand, explain, and intervene in social inequalities related to oral health. Although intersectionality represents progress in this field, we must also acknowledge its limitations alongside the concept of social class from a new Marxist perspective. So thank you very much for the opportunity to share my recent reflections on this area. Thank you so much.
Thank you, Marco. Thank you very much for this brilliant presentation, very thought-provoking, definitely, on this key aspect of theory and conceptual foundations of inequalities research. I'm sure there are some questions, comments out there. Hold them, hold them. So now thinking about the time, let's move on now to discussing some methodological and also theoretical approaches to oral health inequalities research. And in the core project, we have been using diverse approaches to understand inequalities and how to tackle them in different contexts. So now we'll hear from the brilliant Ankur Singh. So Ankur is an associate professor at the University of Sydney School of Dentistry. He's also the vice president of the Goharn Network and IADR. He's honorary principal fellow at the Melbourne School of Population and Global Health at the University of Melbourne. And Ankur is an international collaborator of the core program. Also, dear friend, lovely to have you here, Ankur, and colleague. He is one of the few people I know who is brilliant, both conceptually and methodologically in dental public health and inequalities in particular. Welcome, Ankur, over to you, and thank you for being here.
Thank you so much, Carol. Can you confirm if you can see my slides?
Yes, we can. Thank you. Yeah.
Thank you. You've
I'll
put
let
me
you
in.
know when. 2 minutes are left again. Yeah, sorry to interrupt, but
No
thank you.
problems, no problems. And thank you. You've given me a difficult task today, to follow up from such a wonderful presentation from Marco, who also happens to be my PhD supervisor. So I hope I stand up to it. What I have done in this presentation today, I've tried to sort of share some reflections, conceptual reflections, challenges, I think, particularly when we work with people outside of health and equalities field. And then the second part is about some practical solutions, I think, that we need to perhaps, apply more in our subdiscipline of dental public health on the social inequalities in oral health. Now, before I go any further, I'd also like to acknowledge the traditional owners of the land from which I speak today, and I pay my respects to the elders past, present, and emerging. I think this audience knows it very well, but it's still very important to highlight what are we dealing with, which is the wicked problem of social inequalities in oral health. It's a persistent problem, right? And if you have resources, if you are wealthy enough, if you have resources, you're likely to eat better food, will be able to adopt strategies to mitigate stress, apply the knowledge on harms of tobacco and alcohol use, be more physically active. You will have low incidence of disease to begin with. You already have an advantage. But then some of you, if you are unlucky, and then you get the disease, there's a dentist next door who will convince you that every 6 months they can take responsibility of looking after your teeth. And if you end up buying private health insurance in Australia for that reason, you might actually end up getting more money from the government from private health insurance benefit and tax benefits. So it's just amazing, like how the system is skewed already to create that inequality, and how it is supporting if you are on the better end of the spectrum. But what if you don't have resources? What solutions will you have? It's really interesting. If we did a recent study, and Anupul did a fantastic job at this, where he quantified as such what's going to happen if you reduce poverty on oral health outcomes in the US adult. And he uses fancy counterfactual stuff. But one of the striking things, and particularly which came across, was that absolute poverty may not be such a big issue in the US, but the relative poverty, if you look at the extent, a reduction of 50% in relative poverty would avert 5.4 million cases of perio, 3.8 million individuals with caries, and about 2 million cases of dental pain. So we all know poverty can be addressed, and we all know high-income countries have enough resources to address it. But there is the lack of willpower, there's the lack of politics to do that. And this is just an example, a counterfactual scenario, that if it was adjusted, what's going to happen, the benefit at a population level. But people experiencing social disadvantage are often forced to find time, opportunity, and money. And all of these things are scarce in combination sometimes. And their competing priorities are relentless. And this is just one version of this disadvantage. And I mean, being an epidemiologist, I've come to this very clear realization that there are countless stories unseen and unheard that epi and quantitative data cannot look at. And qual is absolutely, absolutely critical in that space. So we have to have interdisciplinary and multidisciplinary teams like the core really offers. But how can we solve this wicked problem? How can we be generating evidence that shifts this dialogue? The first thing is focusing on upstream interventions. So for those of you who don't know this person was Professor Richard Cash. Richard Cash was someone who believed in upstream interventions. And one of the upstream interventions was the cheapest upstream intervention he ever devised with his friends, which was the oral rehydration solution in Bangladesh, to protect lots and lots of children dying from dehydration. Such a cheap, easy solution applied at a population level saves so many lives. But there was something really interesting someone had written in Lancet about Professor Cash, which was Cash respected technology, but felt that it had been overplayed and that it had captured the attention of policymakers, healthcare financiers, and the medical community at the cost of low-cost interventions, which could have had a much greater population impact. And I think our discipline as such, dentistry, suffers with it. The fancier things, the more hyperclinical interventions, they always get more airtime than the population interventions, which can actually be shown to A, reduce the public health burden of disease, but B, also to the inequalities as such. And unfortunately, we need advocates like Professor Richard Cash who can make it materialize in oral health. And then let's look at, sorry, I'm going backwards. That's not the plan. And then let's look at how we can build this up. I mean, the first thing I'll say is we need better, I mean, yes, we have a lot of descriptive data on inequalities, but I think it could improve. I still feel that it could improve. A, the measure of inequality, and Marco did a fantastic job talking about what we measure matters, whether we measure social class, whether we measure income, all of them have different causal processes through which they affect outcomes. And it's important to underline that. The scale, I mean, you could see a reduction on one scale, but you could, at the same time, you could see a reduction, increase in relative scale. And I mean by the scale, the absolute and the relative scale. The meaning of it, and it's really important. What does it mean? Like what really drives inequalities? Can you intervene? So it's great to map inequalities, but if you can't really change it, what help does it do? And the level of aggregation, again, I think great that Marco had already covered the bit about how social disadvantage can be measured at individual as well as aggregate levels. But the second bit is really daunting, and I'm coming to terms with it, and it's becoming harder and harder to understand because this really goes deep, is how do we set clear goals for reducing inequalities in oral health? Because every time I go to a public health agency over here, clearly, I see they have built-in goals about reduction overall burden of disease, and that's very clear. But there's never a clearly articulated goal, quantifiable, about to what extent we'll achieve reduction in inequality in the outcomes. And I think this is a fundamental problem. And the last bit is how can we evaluate impacts of interventions on inequalities in oral health outcomes? So for monitoring inequalities over time, this is a really interesting example and a tool that I think a lot of people can use over time, which a colleague of mine, George Tisney from University of Melbourne, devised. So you can see this is the smoking inequalities, so differences in smoking status by disability among low, middle, and high income group. And you can see overall, everywhere you can see a good story that the smoking prevalence is going down across the groups. What's really interesting when we start looking at absolute and relative inequality together, really interesting picture. So on your x-axis is the smoking prevalence in the advantage group, which is the people with without disability. On your y-axis is the absolute inequality. And on these contours is the relative inequality. And what is really interesting, and I know Marco spoke a little bit about intersectionality earlier, but see what is happening. So the inequality, disability-related inequalities in smoking from 2000 to 2020 is gone dramatically down in the highest income group, which is, going both the relative inequality is going down and the absolute inequality is going down. But as you go in the low income group, both the relative and absolute inequality is going up. It's really interesting, the contrast you can see. So that's where I think the tools used for monitoring inequalities and presenting that to policymakers can be much more powerful in oral health. And then I spoke a little bit about it, but I think the bigger problem I feel is that why the effort of measuring it if you can neither articulate clearly the target goal and never ever quantify the extent to which interventions reduce inequalities? That magical one we think that will come and eliminate inequalities is never going to happen. So we need to have realistic discussions and hold people accountable to the extent we want people to deliver reduction in inequalities in oral health outcomes. And finally, I just touch on some methods, epidemiological methods that I've applied, and I've found they can really drive evidence in terms of reducing inequalities in oral health. I mean, one is the causal mediation analysis, where you can actually in longitudinal observational data have temporal ordering between confounding factors, exposure, mediator, and outcome. And you can then quantify to what extent the inequalities will be closed if you were to intervene on the mediator. So in this case, we looked at how much inequalities by financial hardship and multimorbidity can be addressed if we were to intervene on social support. Now, there is a further advancement of this. In this, we quantified the natural direct and the natural indirect estimates. But actually, the recent causal methods also further, in the interventional causal mediation analysis, allows you to see exactly what's going to happen if the same level of resources in terms of the mediator were given to the disadvantaged group as much as the advantaged group. What would be the change in the outcome? And that is really powerful from an equity perspective. That is saying what's going to happen counterfactually if we lifted the level of mediator in unexposed to the exposed levels. But then we also know relative risks do not speak to the public health impact. I think it was very clear, and this is a really insider story. When we were writing Uppal's paper, again, on the impacts, it was dramatic. The relative risks look tiny, but when you convert it in terms of what's going to happen in US population with poverty, the magnitude looked massive. So you really need to understand the impact, and always relative risks don't speak to that. Also, policymakers need to compare interventions across a number of measures as there are finite resources, and their interest can vary across all of these things, which is public health benefit, economic impact, equity impact, and so on. And finally, no policymaker is funded to go back in the past to change things. They always are thinking, in future. So really, how can we address that? And I have spoken a lot about these. I think they are very underutilized. Which is the proportional multi-state life table models, where you can simulate the impact of interventions on, across different population subgroups within a population. And I know, for modeling, it's always said that what goes in comes out, but also it is really important when there's no modeling, you basically have no idea of what's going to happen in that space. So it gives you at least a perspective of what the intervention impacts would look like. But I would again like to reemphasize, particularly for the GORE group and the people based in low middle income countries, that opportunities exist in terms of leveraging even GBD data for that purpose. And over here in this modeling exercise, we leverage GBD data for Solomon Islands, which obviously lacks, primary data on a lot of issues around tobacco and health impacts of it. This is another example I've shown earlier, but which is really intriguing and interesting, how simulation modeling can help people make decisions, which is, again, what you see here. On your x-axis is your health impact. On your y-axis is change in inequality. You've got interventions which give you nothing in terms of public health gains and actually increase inequalities. There are interventions which are very, very good, both in terms of public health gain and reducing inequalities. And there are some interventions will dramatically reduce inequalities. So the policymakers can make informed decisions about selecting interventions and perhaps scaling them up or integrating them by looking at comparative analysis of interventions, which, again, I think for 2 minutes.
Yeah, thank you. Sorry.
I'm getting close. Yeah. So I think that's really important. And what we have been doing with at this end, and for those of you who are probably coming to IADR, would be able to see the outcomes of this simulation modeling we've done for sugar tax and SSB beverages in the US, and to see the inequality impact of those interventions. But as you can see, these are not real numbers, these are made up numbers. But what we are able to now do within our group, with our base model, to actually show how perhaps the combinations in terms of interventions and population subgroups can give you lifetime tallies in terms of under intervention compared to business as usual. So I'd like to really summarize and leave with this, that if we are actually serious about addressing inequalities in oral health, we must move beyond just describing the problem to actually actively evaluating whether our interventions ever close the equity gap. And this requires not only strong data and advanced methods, but also the moral clarity to set targets, measure progress, and hold ourselves accountable for ensuring that the benefits reach where they're needed. Thank you. With that, I'll close the presentation.
Thank you so much, Ankur. Again, as always, great presentation, combining, conceptual and methodological inputs. I'm sure this is again provoking. We'll have the chance to discuss later too. So now I know I'm aware of the time. So let's take a look at another methodological discussion on oral health inequalities research. And in the core program, we have been using qualitative research to understand how inequalities are embodied by people and how different communities experience exclusion in oral health. So our next speaker will share some general aspects on qualitative research. Unfortunately, he cannot be here, but he sent his recording. So our next speaker is Professor Al Ross. Al Ross is a chartered ergonomist and psychologist and professor of health systems at Staffordshire University, where he is the course lead for the MSc in Human Factors for Patient Safety. Al's research applies human factors and general system theory to patient safety, service quality, and public health. Al is part of the core program team, and I will share my screen. Hopefully you can see and hear the recording, but please let me know if there is any problem. Let me maybe just turn off the video and I'll share my screen. Oops. There we go. That's the one.
I'm Al Ross. I'm Professor of Health Systems at the University of Staffordshire, and this is a short talk which is intended as a basic introduction to the tools or procedures of quality, namely interviews and facilitated focus group discussions. It is necessary first to briefly outline theory, because what makes qualitative methodology or qualitative research is theory about the world plus method or procedure for applying that theory and carrying it out. I'll cover some procedural considerations for people engaged in qualitative research and then say a little bit about analysis of the data that are generated from these procedures or methods. I'll also draw a few short illustrative examples from the core community-focused oral health research for equity project. What is perhaps not often talked about is that quantitative research, which you may be familiar with, has a theory too. It has a theory that underpins its methods and procedures. I tend to call that naive realism. That's the idea or the theory that the external world is real and it just appears to us more or less as it is. This is closely aligned with what we call positivism. That's the scientific study of that objective reality. And quantitative methods follow from that. They are ways to study and measure that reality. And the scientist is supposed to be value-free, we say disinterested, and merely, if you like, the finder and reporter of facts about the world. This has become conventionally coupled with experimentation and statistics in recent times. And so these facts are most often represented, for example, as general statistical laws or effect sizes. The contrasting theory, if you like, that underpins qualitative methods is generally called constructivism. Sometimes you might also hear critical realism. So constructivism has it that we don't and can't simply passively receive facts about the world. Rather, we filter and we build our understanding. That's the construction. So we're more active, if you like, in the scientific and interpretive process. This is coupled with a focus on how people experience the world. That's what we call phenomenology. As opposed to seeing how it is as being somehow separate, we privilege this idea of how people live in. We talk about things like lived experience. You might also hear the term ethnography or ethnographic. This means really just immersing ourselves in that world, the idea of gaining a deep dive understanding and a rich understanding of a community, culture, behaviour, and so on. So often we might combine interviews with observations to that ethnographic end. We're going to cover some associated qualitative methods in a second, but I would argue that the main consideration when discussing quantitative versus qualitative designs, if you like, studies, is what your research question is. So what is it you're looking to find out? We'll provide these slides so you can look at these questions in your own time. But generally, quantitative is good for prediction and comparison, for making definitive decisions, for example, to drive treatment guidelines or to drive the use of scarce resources. Qualitative is good for process. How do people experience care? It's good for going back to foundational principles. What does oral health even mean to people? And it's good for complexity, for addressing really complex.
Oops.
Now, some ethical considerations are just the same, really, for quantitative and qualitative designs. Namely, those to do with consent and confidentiality. We want to give participants information so that their consent is informed. And we want to protect confidence when reporting so people are not identified. And we have a duty to report, for example, where people disclose events that indicate a safeguarding issue and so on. But there are some aspects of procedure in qualitative terms that raise their own considerations, mainly because people or groups will be identifiable. We may gather observational notes or tape recordings or video recordings. These may be hard copies or stored on a cloud if we use an online platform. And we need to consider who can access these, how to store them securely, how long to keep the data for, and so on. It's important to think about analysis in advance when thinking around the ethical arrangements for a project, because qualitative data are generally quite hard to analyse and report on. So, for example, we may benefit from transcribing them or typing out interviews, but that may mean a third-party provider has to have access to the data for transcription, so that needs to be part of it. One addition to that fairly general ethical picture is setting. Setting is more of a consideration in qualitative research. We may often be conducting the research in a place to suit our participants rather than bringing them into a clinic or a lab, for example. We may wish something to write on. We may need power for devices. We probably need some form of privacy in a busy setting to allow people to disclose in confidence. We want to be able, obviously, to see and to hear when interviewing or note-taking, so we have to give consideration to that aspect of the environment. And we have a duty of care to researchers and participants alike. So a wee bit of planning is all that I'm really advocating here. And piloting strongly suggests going to the setting before you try and do an interview or focus group. Check the lighting, check the power works, check the privacy, check how busy it is at different times and so on. A wee bit of time spent in advance on the setting can save a number of issues later on. And that should really be built into your ethical treatment. You know, how are you going to deal with interruptions and so on and so forth as part of your research? Interviews and focus groups will generally employ what we call a semi-structured interview model. This means we have a guide to what we want to ask, and that would be included in your ethical treatment. But we can be flexible in response to what people say and the way discussions go, so we can prompt and ask for clarification and ask for more information and so on. We're free to explore within the semi-structured framework. Again, piloting is key to see what questions work, whether participants understand the questions, whether we can get them to talk about the subjects and so on. Generally, we want people to be comfortable and to feel free to speak. So we can stress confidentiality again, really ensure people's trust. And we have to try and get them started. So it's a good idea to allow them just at the beginning to introduce themselves, say a little bit about themselves and so on, which opens up the voice and gets us going. When it comes to recruitment, we want to remember the theory. We're interested in people's lived experience. So we generally recruit deliberately, we say purposefully, to get a range of views and experience. It's not so much about generalizing to a wider population, like in a conventional sampling model. So we not generally talk about representative sample, but rather that we want to gather a range of different views, lived experiences of the phenomena under investigation. We're exploring a topic rather than testing an intervention, so we are free to recruit people that we think can answer our questions. So we're not thinking about things like control, we're thinking about range and depth. Key question that people will often ask is how many people do we need to talk to? Because we don't have that, if you like, power calculation model. The sample is usually decided on as you go under the principle of saturation, which is simply the idea that eventually you get no new experiences or views being expressed or coming through, as you've covered everything and you've spoken to enough people and a range of people. You might start with an initial number and then revise up or down depending on what's coming out of your data. So a guide might be 12 interviews and maybe 2 focus groups of 6 people or thereabouts, but that's not set in stone at all. I think the ORS model here from motivational interviewing is potentially a useful thing to have in mind in terms of the style of our interviewing and of our focus group facilitation. And we want to ask open questions. I'll show an example of that in a second, and not direct questions that would lead to yes/no responses. Then we can probe, however, and follow up on things people say. We're allowed to affirm, so we're allowed to, if you like, feedback naturally to what people say. Say, oh, that sounds good, or that sounds difficult, or I empathize with what you're saying, and so on. So we're allowed that affirmative model. And an important part of qualitative work is listening. Really want to let people give their experiences, not be too fixed on the topic, guys. So if people are talking, I would generally say let them talk. You can use your non-verbal skills to just encourage people around a room or a focus group or just in an interview, but to show you're interested and to show that you're listening and to show that you want them to keep talking. That's always a good idea. And you're allowed to summarize. That potentially is more applicable in focus groups. To keep the flow going, you're allowed to say, okay, well, it sounds like this is what I'm hearing. What does anyone else think? Or is that subject now being covered? Do you want me to move on? And so on and so forth. You're allowed to summarize, bring people in, and keep the flow going. You may want to consider which you think is the easier method to arrange and to conduct. One thing I would say is that the bias is always at risk. In interviews, it's very direct. The questions you ask will directly influence data. In focus groups, it's a little bit more indirect, but what you have to potentially watch out for is that some voices or some participants will dominate conversations. So that's a form of bias that you have to try and get around by making sure everybody has the chance to feel safe and to express themselves. Again, if I can finish with some examples, but then repeat that you have these slides and you can have a look at these in your own time. So this is just an example of what we mean by a nice open question to get people started. This is from an interview in Colombia. How's your experience been? That's the question. And as you can see, people then, if they feel comfortable, come forward with a whole load of really nice, rich information. Here's an example of one of those affirmative follow-up prompts. This is from the UK, where people are talking about their experience of people growing up with false teeth or dentures, and the interviewer says, that's really interesting. Do you want to say more about that? We can see that little interjection, just to keep the flow going, encourages further participants to tell us more. And again, from these examples from Kenya, hopefully you can see some of the theory come through. We start off really open to get people talking, but we're asking about conceptual stuff. What do they recognize as a healthy mouth? And then getting into some of their lived experience and their local context around access to services and so on and so forth. Analysis is difficult to cover in a short talk, but I do think that transcription can help. It gives you time to think about your interpretive analysis in line with your research aims and questions. In general, the analysis is aligned with the theory and the procedures and the methods, as you might expect. We're looking to collate that lived experience. So we would normally talk about themes or wholes. So our findings are normally in narrative or storytelling form. They're interpretive, so we're trying to get inside the data, again, with that ethnographic model. And we talk about induction, whereby we try and generate the themes from the data in a kind of bottom-up process. Against, if you like, quantitative methods, where we're testing something from the top down. That's all we'll really say there today. We're trying to, again, explore, show the richness, the complexity, to describe, and to generate, if you like, sometimes new ideas. So we talk about theory generation in qualitative. It's, of course, rather than theory testing. And the last thing I would say is you can embrace, again, because of that constructive model, you can embrace your own role in the process and be reflective about what you've learned, what you've found out, how your own biases and so on affected the data. And another slide we can leave you with is this one from our qualitative work. And this is a thematic relational model trying to make sense of that exploration of the lived experience of people right across the world in terms of their oral health. So there you go, that's been very quick. We have a constructivist worldview in qualitative research. We've privileged lived experience of phenomena. Therefore, we can go and look for people purposefully to answer our questions and to give us their experiences. We have flexible methods that we can use whereby we can adapt and prompt and probe to gather data as we go along rather than a fixed protocol per se. And we construct thematic narratives. And hopefully the stories that we get add to the picture. And they're just one string to our bow, if you like, as we try and improve people's lives and health outcomes. And I'm very happy to be contacted with any points you'd like to raise or any questions you have.
Okay, so that's our last presentation. Time flies, I know, but I think we have time for a few questions. So please, please raise your hands, open your microphones, or if you prefer, please, include your questions in the chat box. Sorry, I was sharing a screen, so I don't know if there are already questions in the chat box. I think there are, right? Yes, I can see one here. The first one I can see for Anchor. I appreciate your wonderful presentation. I have a question about the last slide. If we proceed developing intervention strategy, what kind of research or analysis should be done for future in addition to today's, your example? If you have more insights or papers to read, I would like to know. Thank you. Oh, okay. Ankur, you replied already. Sorry,
Yeah, I'll
because I
try
was
to
sharing
answer
your
as I
screen.
speak. Yeah, no, but
Okay.
as I think just to re-emphasize the
Mhm.
value of creation approaches and really thinking about co-design, co-creation, setting those power imbalances in designing interventions is quite critical.
Great. I think that's absolutely key. And again, hopefully we'll learn more about this co-design and co-creation of those interventions strategies. That's one of our aims at the core program. So challenging, but very exciting. Okay, I think we have more questions here. Paulo, thanks for this nice webinar. Just to comment, I will say that from South epistemic point of view, we need a revolutionary theory to only measure the actions, to not only measure the actions, but also how people perceive them, feel how the life become better, is what we are looking for. I don't know if you guys would like to comment on that, maybe Marco.
Yeah.
Thank
Thanks,
you, Marco.
Paulo. Now, just to paraphrase in that, people say that what we need, Paulo said, is a revolutionary theory. I can add that we need a radical theory. And radical, some people, so etymologically speaking, radical comes from the Latin radix, which means root, the fundamental cause. So that's the what I try to touch is the criticism of intersectionality, because the criticism that apparently is radical, but for some of the scholars that I mentioned, it's not, because obscure the fundamental, so the radical, the fundamental causes of inequalities, that the structure of the society. And this is quite interesting, and I think that we are a bit shy in denouncing the structure. We are talking about inequalities, but we omit some of time, or most of times, the fundamental cause, that the way that the society is structured. And that's what these scholars propose to us, a more radical approach, if you like.
Thank you, Marco. That's great. Thank you so much. So I think we have one more question in the chat. Can you share some insights based on community voice? What are the policy interventions, I guess, that we might suggest to reduce the oral health disparity gap? So Ankur, Marco, if you want to comment on that.
Marco,
Well,
do
I
you
guess.
want yeah, sorry, Carol, go ahead.
No, go ahead.
No. Yeah, just perhaps Ankur can add on that. But initially, some very well-known epidemiologists proven that actually, in the beginning at least, interventions or very successful preventive measures tended to widen socioeconomic inequalities, and then they call this as the inverse equity hypothesis, which means that those people with more power or more educated or richer trained to capture the benefits of those measures earlier. So actually, we need to be very careful, because some, well perceived for us measures actually tend to widen socioeconomic inequality instead of reducing. Like any comments on that, Ankur, please?
I think it's a very important point, Marco. I think what often happens that sometimes small community-based interventions are well intended, but we for sure know that if they are not scaled up, and if they are scaled up, the ones who would likely to benefit more are people with advantage. And there's always that risk that those interventions in long term can generate more inequalities rather than with the intention to reduce inequality. So it's really important to think through that what's the nature of the intervention? Can it be scaled, and can it still reduce inequality over a long period of time? So just, I mean, I think the point is that the intentions are not enough. I mean, you really need good quality evidence to show that an intervention will reduce inequalities. I would again say, I mean, that was the stuff about Richard Cash where I was trying to go with technology. It's very important. Again, artificial intelligence really, lots of opportunities, but it can also be both a key driver of inequality, or if not very carefully thought from a social, from an equity perspective. So I guess it's a very important consideration, and that's why we need better evaluation of interventions for equity impacts.
Thank you guys. Very important topic. There is an interesting literature review published years back in JEC, I remember, called like What Interventions Cause Inequalities or something like that. Still very valid, and kind of points out towards saying the upstream, the intervention, interventions really modifying working, living conditions, even some of the taxation policies, those seem to be more likely to reduce the gaps rather than downstream interventions. But this is a really interesting topic. I am sorry we don't have more time, I think, for questions. Just one more maybe in the chat box. It says, Gisela, I have a question. In a phenomenological study focused on the lived experiences of families of children with disabilities, how can we meaningfully connect the structural inequalities to the analysis? I'm aware that the phenomenology centers the subjective perspective, but in a complex issue like oral health care in disability, the problem is embedded in structural, relational, and subjective dimensions. I would really appreciate any suggestions or reflections. I think we can connect Gisela to Al, who is an expert in this kind of analysis and is actually leading the qualitative analysis in the core project at the global level. We also have qualitative analysis experts at the local level, but yeah, I think that will be something worth discussing, and definitely the use of qualitative approaches and mixed methods in oral health inequalities research is something very important and probably something we should explore further as we move forward. So if you don't have any further thoughts, Ankur, Marcos, thank you so much. Let me just quickly, everyone, share with you some very quick information, I promise. I know we are over the time, but just wanted to share, the next IDR general session is coming very soon in Barcelona, so please find us there. The core project will share some of our initial findings and the project general design as well. And find us also in our social media channels or website, email. We will be there. And please join us for our future webinar sessions. So the next one will be focused on commercial determinants, and that will be the 25th of July at the same time. Oral health system research, that will be after the summer break, 25th of September, and community engagement and involvement, that will be the 30th of October. So please join us for those webinar sessions. Just a reminder, all our program, all the research is funded by the NIHR Global Health Program. And please give us your feedback on this webinar on the form that I think is already in the chat box, the link as well. Thank you very much. Apologies that we run over the time, but it has been a brilliant session. Thank you so much. I'm sorry, Ana Beatriz, I just saw your hand up, but yeah, I think it's time for us to finish. So sorry, please, if you want to keep in touch by email. Hola, Marco, gracias. Thank you, everyone. Abrazos. Thank you.
Thank you. See you in Barcelona.
See you in Barcelona.
Bye-bye.
Thank
Bye-bye.
you.